Okay. We'll wait for another 3 minutes. Is my screen visible? Okay. I'm not able to see my screen. Please hang on for a couple of moments. I think I have a problem with the software. Guys, is my screen visible now? ಅವ್ರು ಇಲ್ಲೇ ಬಂದಿದ್ರು ಒಂದು ನಿಮಿಷ ಫೋನ್ ಮಾಡಿ. I don't know if they're able to see the screen because I have muted them. So
ಯಾವ್ದೋ ಒಂದು ಮಾಡಿ ವೇಸ್ಟ್ ಆಗಿದೆಯಾ ಡಸ್ಟ್ಬಿನ್ ಸೇರಿದ್ರೆ ಮಾಡಿದ್ರೆ ಅಲ್ಲ
Guys, can you hear me? Yes. Okay, I'm trying to cast it through my mobile. So if you have any problem, do let me know. Okay, I'm gonna start now. So we were talking about diseases of lens. We discussed about different types of cataract, and today we'll be talking about pre-op evaluation and the surgical techniques for cataract. Okay, a quick revision. First of all, we begin the examination with don't worry about the attendance. Just hang on, please. All of you will get attendance. Whoever enters the class now will also get attendance. No problem at all. So, firstly, we'll do ocular examination. The most important is visual acuity assessment, for which we'll be using something called a Snellen's chart. So, in the picture, you can see the Snellen's chart, which we use to measure distant visual acuity. So, we usually test each eye separately. Um, when we are testing one eye, the other eye should be closed, and we begin with the lowermost line. This chart, we'll start with the second last line, that is 6-6. If patient is not able to read 6-6, then we move further up. If he is able to read the next line, it means 6-9. And after that, it's like 6-9, 6-12, and so on. The topmost line, if a person is able to read the topmost line, the vision is 660. And if you're able to read the bottommost line, it means your vision is 6.5. That's called a supervision. So this is the chart. This is how the Snellen's chart looks like. If a patient has a very dense cataract, if the media is totally opaque because of cataract, then it is very important that we look for perception of light and also projection of rays. I've already explained the procedure in the previous class. So that could be a viva question, how to do the procedure. And there's something called as potential acuity meter. Uh, Again, that can be your viva question. So this is an instrument which we usually mount on the slit lamp. And what we do is, we don't have this instrument in OPD, but this is used to assess the visual acuity that a person can get after undergoing cataract surgery. So this test is done in patients with medial opacity. Okay, moderate to little advanced cataract. Uh, this test will give us an idea about the visual acuity that patient can have after undergoing cataract extraction. So this test usually involves this instrument called as potential acuity meter, which we mount on the slit lamp. And what we do is, we throw a small, very narrow beam of light onto the patient's eye. And through that aperture, patient is shown Snellen's chart. So the Snellen's chart, through a very narrow beam of light, the beam of light will be around 0.1 mm, that small, and it should fall on the retina. Usually the opening is in front of the cataractous lens, wherever the cataract is little less dense, just to allow the passage of light. Um, that is how we do this test. So in the picture on the right hand side, first of all, that is the slit lamp. That is how slit lamp looks, and the instrument attached to the slit lamp is a potential acuity meter. I'm not able to move my cursor, nothing. So kindly adjust. And on the left-hand side, the chart you're seeing is called as Jaegers near visual acuity chart. So visual acuity assessment will involve distant visual acuity and near visual acuity also. It is to be done in all patients. So this is how Jaegers chart looks like. And next is anterior segment evaluation. I think this was taught to you very recently, how to go about examination. You have to see if there's any pathology, if there's any foci of infection in all these ocular structures. If any infection is present, please treat that first and then plan a cataract surgery. Otherwise, we could end up with a dreadful complication called as endophthalmitis. So we examine each and every structure in detail on slit lamp. In eyelids, you look for any stye, hordeolum, or any meibomian gland dysfunction. If it's there, treat it. Lacrimal apparatus, we see if there's any dacrocystitis. If present, then we plan for DCT or DCR, whatever is indicated in that particular patient. And only after that, maybe a month or so, we plan cataract surgery. Next is conjunctival examination. We should see if there's any conjunctivitis or any inflammation like pingula or inflamed pingula or inflamed pterygium. In that case, we'll have to treat that condition first. And once the eye is quiet, we can plan cataract surgery. Then examine the cornea, see if there's any defect on the surface, see if cornea, the most important thing is we assess the endothelium also, because endothelium has its endothelial cells, and the normal endothelial cell count is 2000 to 2500 cells per square. And after any cataract, after any intraocular surgery, we can expect some endothelial cell loss. But if the endothelial cell loss is too much, then patient the cornea will not remain clear. It lose its transparency. So we have to be careful in people with lesser endothelial cell count. So we can take extra precaution during surgery, and we protect the endothelium during the surgery. And see if there's any deposits on the endothelium layer, that is called as keratic precipitates. So if you see any deposits, you have to see if there's any ongoing inflammation in the eye. If it is old KP, which suggests that it was an old uveitic condition, then you don't have to worry. If it's active, you'll have to treat uveitis first and then plan surgery. Anterior chamber, again, look for any inflammatory reaction in the anterior chamber. Then, okay. Then examine the iris, see if the iris pattern is normal or not. Pupillary reaction is very, very important. See if it's like normally reacting, briskly reacting to light. So we do direct light reflex and indirect light reflex. Once you throw light onto the pupil, you will have to see, there should be sustained constriction. So if the pupil does not constrict, instead it starts dilating, then that condition is called as relative apparent pupillary defect, that is RAPD. So in that case, patient, then you'll have to tell patient that he might not get back his vision after the surgery might not be that great. So you'll have to tell patient that the surgery will be done under guarded visual prognosis. And lens, definitely to know the density, the kind of cataract, because especially if you're planning phaco, then you'll have to know what settings you'll have to do in the phaco machine and then plan the surgery. If it is hard cataract, some people might not even try phacoemulsification. We would do SICS, which is safer. For hard cataract, SICS is a little safe, especially for beginners. Experienced surgeons can still plan phaco for hard cataract. So it's important to know the density of the lens as well. Next, IOP, we measure IOP, that is intraocular pressure. By now, you know what is normal intraocular pressure. It is 10 to 21 mmHg. And you measure IOP using one of the three instruments. The left corner picture is the picture of Schwartz tonometry. On the right-hand side, the first picture A is non-contact tonometry, and the picture B is Goldman applanation tonometry, that is again mounted on slit lamp, and we measure IOP. That is the gold standard technique of measuring IOP. All these instruments you can see in our OPD. And picture C is something called as Perkins tonometry. Again, it can be a viva question, different types of tonometers. fundus examination is extremely important to know if posterior segment is normal or not. So the instruments that we use to evaluate fundus is direct ophthalmoscopy, indirect ophthalmoscopy, and something called as fundus biomicroscopy, where we use a uh, lens such as 78D or 90D, and we do the fundus examination on slit lamp itself. So that is fundus biomicroscopy. In the picture again on the left hand side, this is a picture of direct ophthalmoscopy, and on the right hand side, the instrument that the examiner is wearing is indirect ophthalmoscopy, and along with that, you will have to use something called as condensing lens that is placed in front of the patient's eye. Um, so that is how indirect ophthalmoscopy is done. It is a head-mounted instrument, and we use condensing lens. And indirect ophthalmoscopy is very important in cases with dense cataracts, because in direct ophthalmoscopy, if media is too hazy, you cannot examine the fundus. So in hazy media, we prefer indirect ophthalmoscopy to examine the fundus. Again, you can see these instruments in our OPD. And we do something called as a macular function test. You do it when the media is very hazy, when you cannot visualize the fundus, even with IDO, if the cataract is mature or hypermature. If you're not able to see the fundus, then you would like to know if the macula is functioning normally or not. Some of the macular function tests are this is your can be your theory question, 5 marker. So the tests are 2-point discrimination test. I think I've already explained the procedure. We follow rule of two. Again, we make the patient sit in a dim lit room, and we occlude one eye and examine the other eye, and we put a pinhole in front of the patient's eye, and at 2 feet away, we show the patient two targets, okay, mostly illuminated light, which is 2 mm in diameter, and those two lights are 2 inches apart, and those two lights are 2 feet away from the patient, and patient has to see through the pinhole. If the patient is able to distinguish uh, that there are two lights that are seen, then patient's macula is functioning normally. That is the procedure. I don't think your Purana has given it properly. So that's for 2-point discrimination test. You can refer other textbooks for that. And then there's something called as Maddox rod test. I'll show you the picture in the next slide. I'll tell you about it in the next slide. And then there's color perception test. There are two lenses available. One is called as red filter, and another one is green filter. We make the patient wear the trial frame, and we put the lens in front of the eye which is being examined. Then we ask the patient if then we shine the light. This patient is able to, if we put the red filter in the trial frame, then patient should see a red light. If we put green filter, then patient should see green light. So if patient is able to perceive both red and green, it means that his optic nerve is functioning normally. And other tests that we do to evaluate retina is ultrasonography, B scan. That will tell us about the anatomy, especially B scan. It will tell us if the retina is attached or detached. So gross anatomy, if there's any vitreous opacity or hemorrhage in the vitreous cavity, all that we can find out from B scan. And other things are electroretinography and response. This is a picture on the left-hand side. Filters above red mobile screen full blank ಇದೆ. And another is green paper. We use these two papers for color perception test. And below you can see two other lenses. This is box rod consists of series of cylindrical rods. So how to do this box rod test? This test is very sensitive. We assess the macular function, and the light source is placed around 40 centimeters from the patient. And again, each eye is tested at a time. It is a uniocular test, and we occlude the fellow eye. So it's a if a patient has a good macular function, then it's a Maddox rod. When you show a point source of light, patient will. Yes. So when you show a point source of light, when the patient is seeing through the Maddox rod, then he or she will see a vertical line of light that you can see in the picture. After the evaluation, guys, please cooperate because I'm presenting through my mobile phone. I don't have the option to mute all users, so you have to do it on your own. Somebody's talking in the background. Please turn off your mics. Am I audible? Guys, can I continue? Load ಆಗ್ತಾ ಇಲ್ಲ ಅಲ್ಲ? ಆಗ್ತಾ ಇದೆಯಾ? ಆಗ್ತಾ ಇಲ್ಲ. Okay, somebody can turn on your mic and say yes because I'm not able to see the chat.
Yes, ma'am.
Okay. Thank you. Was Maddox rod clear? Should I repeat? At least in messages ನೋಡ್ಬೋದಾ? ಇವಾಗ ನಾನು ಈಗ ನಾನು ತೋರಿಸಿ ನನ್ನ ಸ್ಕ್ರೀನ್ ಬರುತ್ತೆ ಯಾಕಂದ್ರೆ ನಾನು ಆಲ್ರೆಡಿ ಅಪ್ಲೋಡ್ ಮಾಡಿದ್ದೀನಿ. ಇದರಲ್ಲೇ ಮುಗಿಸ್ಬೇಕಾ? Okay. After detailed ocular examination, we would like to do other investigations because after cataract extraction, we always implant IOL. Okay, thank you. So we would like to implant IOL after cataract extraction. Okay. So the other tests are keratometry, which is used to measure the corneal curvature. Then we do corneal topography to know the surface of the cornea, again corneal curvature. And we do something called as biometry to use all these values, corneal curvature, actual length of the eye, and we come up with a IOL power. So to calculate the power of the IOL, we do all these tests for each case before cataract surgery. So this is a picture showing keratometry. Again, this is there in our OPD. This is Bosch and Lomb keratometry. This is used to measure the corneal curvature. And after that, before taking our patient for cataract surgery, we would like to do general medical examination of the patient. We have to see if patient is diabetic. If patient is diabetic, then we have to see if his sugars are under control. If not, we'll have to bring his sugars under control. Then only we can plan for cataract surgery, because if sugars are uncontrolled, then there can be delayed healing of the wound. And because of that, again, there can be chance of endophthalmitis and all that. And most diabetics after cataract surgery, there can be some inflammation in the retina called as cystoid macular edema. So we have to bring sugars under control. Until then, we cannot take the patient up for surgery. And we have to evaluate for hypertension as well. And even if patient is hypertensive, it should be well controlled before surgery. Again, if patient has high blood pressures during surgery, then we can face complications like expulsive choroidal hemorrhage. That is more dreadful than endophthalmitis. Endophthalmitis, at least you can treat later on vigorously, aggressively. But if you have suprachoroidal expulsive hemorrhage, then we totally lose the eye. So we have to make sure that his BP is also under good control. Then we have to evaluate for any cardiac problems. Most of adult cataracts, usually we perform surgery under local anesthesia. So most of the times, cardiac problems will not have any problem, but I mean, it will not pose any problem to the surgery as such. But most of us perform SICS, that is one of the type of cataract surgery. And during the surgery, we give something called as local anesthetic block. So, and if patient is on blood, if patient has a cardiac problem, and if patient is on blood thinner like ecosprin or something, then there can be a lot of bleeding sometimes during block. So we have to evaluate for that also, and see if patient has any lung diseases, because during the surgery, patient should be able to lie down for half an hour, and patient should be extremely cooperative during the surgery. Um, and if there's any source of infection in the body, then we'll have to treat that before taking the patient to the OT room. Um, that's about general medical examination of the patient. Next, we'll learn about intraocular lens implantation. So, IOL implantation is the method of choice for correcting aphasia following surgery. So, this is done worldwide now. The real beginning of IOL implantation happened on 29th November 1949 by this English ophthalmologist Harold Ridley. So there's a small story behind it. During World War II, when Dr. Harold Ridley was treating Royal Air Force casualties, he observed that when splinters of acrylic plastic from this aircraft cockpit canopies, when the splinters from that fell in the eye, when it got embedded in the eye, got lodged in the eye, he noticed that it did not trigger any kind of inflammatory reaction in the eye. So he realized that this acrylic plastic is very biocompatible. So if that stays in the eye, then body will not treat it like a foreign body or an antigen, and will not mount inflammatory reaction. So he observed that acrylic plastic is very inert, and it's I hope I'm audible. Yeah, so we realized that acrylic plastic is very biocompatible and inert, and it cannot trigger any inflammatory reaction. So that is when he proposed use of artificial lens made up of acrylic plastic after cataract extraction. So on 8th February 1950, he performed cataract surgery, and he decided that this artificial IOL that is made up of this polymethyl methacrylate can stay in the eye, and we don't have to remove the IOL on a later date. So he decided that this can stay in the eye forever. Lot of advancements happening every day. So we can classify IOLs can be classified based on method of fixation, based on material used for manufacture, based on visibility, and there is something called as fatigue refractive based on sphericity, and based on edge of the IOL, and there are some IOLs with special properties. So based on fixation, IOL can be either angle chamber IOL, and by now we know what is chamber. We are not in. Oh, I don't. There's so much disturbance. Mm, okay. Someone muted me. Oh, that's so mean. Okay, we'll do one thing. We'll stop here. Okay, I can continue next week maybe. I'm really sorry for whatever happened today. It was just hang on. I'll try to save your attendance. Okay, should I continue? Do you have class at 12? No, for what? Is there a class or should I continue? Thank you. No class at 12. What do I do? Uh, okay, we'll do one thing. We'll wind up today. Hopefully, uh, hopefully we'll not have any problem next week. So we can continue next week. But please wait until I save my save your attendance. Please hang on. Don't leave yet. Fine. Okay. I think I'm still in the class. I'm trying to end the class. Are you 60? Um, okay, actually, I'd uploaded. No, I want to save the attendance.